Start.
Yes, ma'am.
Good evening, everyone. This is our third series of Oxy Clinical Skills LCG, Partogram, and CTG. Today, especially, we will be discussing 10 cases of CTG. None other than there are 5 PGs, each two cases they will be presenting. And this program is is a is our Oxy President's program. And Sambat Madam, I owe this program to you because this is your own the logic is like every month one college will be participating. Since this month we will be taking 2 colleges because we have to give 12 sessions, 12 monthly sessions. So we have to give 3 colleges. That's the reason 2 privates and 1 IOG we have given. So today, we have the cases will be discussed from my side. The presentation will be my side, and the students will be discussing about the CTGs. Okay, Sambat Madam,
Fantastic, Deepa. Yes,
kindly tell some few words of wisdom from your part, ma'am.
yes, Deepa. Fantastic. The idea is that PGs and the juniors should know about the CTG. Sometimes will be very, very confusing. So I welcome you all for this CTG and LCG classes. This is the third class, as Deepa was mentioning. So now she will present and the PGs will interact. I think that is the idea of Deepa. I think every month this is done. Thank you, Deepa. Deepa and Dr. Jayashree Gajaraj is the convener for this program. I wish success for the today's program. Deepa, you can continue.
Yeah, thank you, ma'am. So today's program, Jayashree Madam, unfortunately, she could not able to join from London. She is at London Orthopedic Congress. And may I invite our panelist, Dr. Farina from Cloud9, Dr. Fariha from Mehta. She's a second year PG. Farina is a second year PG. And Dr. Ilakia, just switch on your videos, main. Farina, Ilakia, Fariha. And from IOG, Dr. Asha and Dr. Sakti Jaypriya.
Yes, ma'am.
Okay, yeah, both are. So this is Asha and Sakti, correct?
Yes, ma'am. Yes, ma'am.
Yeah. So I just wanted to read the CTG and discuss in this format, the systematic format. If you do like this, then you will never ever forget the sequence of what is the background, what is the CTG, what current scenario of the baby, and what decision you are going to make out. So these are the 2 things I have given. On my left side, there is a CTG stickers which has been taken from the NICE. So it has mentioned white, amber, and red. As you all know, anything comes under amber, 1 line is suspicious, 2 amber colors is going into the pathological category. That means we have to expedited delivery. Amber is suspicious. We have to watch on the baby. Okay. And the Dr. C. Bravoda has been there for a long days. Like almost like it is the 40 years we are doing the Dr. C. Bravoda mnemonics to read the CTG and interpret the DCG and to make the decision makings. Fine. So at the end of the CTG, we will be seeing whether this is a normal baby or is there any pre-existing hypoxia. Is the baby fit to deliver, go through the labor, or is there any hypoxia ongoing, or it is a acute hypoxia. So first CTGs, I will just tell you how to go about this CTGs. Okay. Okay. So this is a case. This is a case of primary 38 weeks spontaneous labors. There is no risk factors. She is gone. So on examinations, just you are seeing this in labor room. Some part of the day, so like this is 1 hour, 40 minutes or 1 hour of CTGs. Vaginal examination, so cervix well effaced 6 centimeters, back of membrane plus, vertex at -2 stations. If anyone is willing, can elaborate and discuss this CTG. Anyone, it's just for everyone. Other than the panelists, anyone for the audience? Okay, so first of all, when you see the CTGs, you just see your x-axis and y-axis. Make sure the x-axis is what? Time in minute. Okay, so make sure your paper speed set at 1 centimeter per minute, which is very important. Okay, yes. And the patient identification is there and the time and date is correctly mentioned. Okay, so this is how you have to see the first CTG. So this is 1 centimeter per minute. So I have to interpret accordingly. The risk category here, what is the risk category here? No, the way
Oh.
C is absolutely low risk. So defined risk category is low risk. Okay, and then the first and foremost, you will be seeing the contractions. Okay, contractions. This is almost like 9 minutes. One from here to here, it's 9 minutes. That is 1 centimeters, 9 centimeter we are seeing. This is one big square is 1 centimeter, which is 1 minute. So if you calculate, this is 9 minutes. So take one more extra from here and totally 10 minutes. Out of 10 minutes, how many contractions you are seeing? So just see every 10 minutes, how many contractions. That's the first things you will be seeing. Here it is 5. And some of the contractions, it is so contractions is number is like whatever it is, intensity, high intensity, low intensity, you have to just tell me the numbers. 1, 2, 3, 4, 5. So 5 contractions, 5 and above is come under the amber. So that is what here we will be mentioning. The 5 and above is come into the amber. 5 or more contractions. So that itself you have a suspicious CTGs. Fine. And what is that? What is this? There are a lot of signal is there. This is called irritable uterus or tonic uterus. Some of the areas it is having high tonic contractions. The rest period is shifted up. The baby is not coming into the rest period. Okay, that is also has to mention the hypertonous contractions. It should not be more than 2 minutes. Though there is no fetal heart decelerations, if you see any more 5 contraction, it is mentioned in 5 amber. That is, it is suspicious. So that is what it is mentioned. That is a 5 or so contraction is, the tone is also high and there is 5 contractions are there, right? Fine.
Yes, ma'am.
Okay. Now, next category we have to read is baseline rate. So baseline rate, where do you read the baseline rate?
X-axis.
Arina, where you read the baseline rate?
Ma'am, we have to say above. Can you go a little close, ma'am? Yeah, baseline is the straight line we see, ma'am.
Okay. So the trick is like where you have in between 2 acceleration, you need at least 2 minutes. 2 minutes means 2 big squares you needed it. So x-axis is time in centimeters, time in minute, and one big square is centimeters. So 1 and 2 minutes. So at least 2 big squares you needed it. So you cannot read your baseline here, which is less than 1 minute. It is 1.5 minutes. So either here or the big green line I have given. That area you can read it. So in between 2 acceleration or in between 2 contractions. Here the contraction is continuous, so we cannot read in between because this is the rest period. The baseline when the in between 2 contraction is the rest period. Okay, so this is where you have to read it. Suppose if you are not able to read this 2 minutes in any part of your 40 minutes trace, then your baseline comes under unable to determine the baseline. Then again it is come under amber color. So here the baseline heart rate is how much?
140, ma'am.
Yes. So you can write 110 to 160 or you will write 140. Which one you will write?
140, ma'am.
Why you will be writing 140?
So if it increases 20 more, then we will know if it is coming under amber or not, ma'am.
Yeah, that's it. If you are examining the same lady after 1 hour or 2 hours, and if there is an increase of 20 beats minute, that time if you see the baseline heart rate 160, still 110 to 160 is normal. Then it comes under amber. That means the baby is going for compensatory tachycardia. Okay. So here you have mentioned defined risk no, contraction is 5, which is in amber color, and baseline rate is 140, which is normal, and the variability. Where do you read the variability? Wherever you read the baseline, the same place we will be reading the variability. So variability is in this 1 minute, how much it is going up and how much is coming down. Okay. So this is the variability. So it's a 5 to 8 beats per minute. That's what mentioned here, 8. And acceleration, are you convinced it is acceleration? What is acceleration?
15 beats from the baseline.
Yeah. So from the baseline, that means it has to arise from the baseline. From 140 beats goes up to 15 beats more and 15 beats come and coming to the baseline. So this is accelerations. Okay. If it is not coming to the baseline, that is not accelerations. Suppose, what is this? Is this an acceleration? Is this an acceleration?
No, ma'am.
Why
No,
it's
ma'am.
not acceleration? Because it is not coming back to the
Baseline.
baseline. So from the baseline, it has to start and it has to come down to the baseline. So acceleration is present. Decelerations, there is no
There is
deceleration.
no
But, okay, is this a deceleration, which is one is coming up and going down and come back, and then coming back to the baseline? Is this a deceleration?
No, ma'am, that's
No,
not
ma'am.
a diesel.
Huh? Sure, that's not a deceleration. Okay, that's not a deceleration, because deceleration, it has to go down 15 beats and stay there and come back, come up. That is a deceleration. So you have to have 15 beats down. Only in places where there is a tachycardia or less variability, less than 10 beats of deceleration is also, you have to consider as a deceleration. Fine. So we will move on to the next. So this is 1 ampere. So what do you do next? It is a spontaneous labor. What do you do next? So you have mentioned it is suspicious.
I'll rupture the membranes and look for the color of the liquor.
Why you will be rupturing the color? Why you want to know the color of the liquor?
If the baby has
Rule
passed
out
meconium or
meconium.
not
What does it
because of the
mean?
pressure.
What is its significance? Your CTG is otherwise fine. Your cardio is absolutely fine. Only contraction is there. Maybe if you continue like this, then the problem will come. Why you need to make the rupture?
She's
By
already in
doing a
active stage.
rupturing- Huh?
She's already 6 centimeters dilated and she's in active stage. So maybe we can expedite the labor.
Why I should expect it? Already she's getting good contractions. It's more contractions.
Like meconium
We
is
can
not
continue
always
monitoring
associated
the
with
CTG.
Okay, so by doing an artificial rupture of membranes, you are promoting more prostaglandins. Already, she is getting more contraction. So you are making the conditions more worse for the baby. So I don't want to, already she is progressing very well. So the membranes can stay for a longer time. That gives us a cushion effect for the baby, reduces the cord compression. So I know by doing a CTG right now, the baby is not at risk. Only the baby is getting the mother is getting high contractions. It may go for hyperstimulation, causing bradycardia for the mother. So we have to reduce the contractions. Why the contraction is there? Ask the mother to do the cope-up mechanisms. That's why here you have to look for why the contraction is she's getting more contraction. Is it anything on drips oxytocin has been started or not? Is she on any prostaglandins? Look for other factors and reduce it. Reduces an anxiety. If there is too much of pain, even if she started putting a premature pain, that comes as more contractions. Okay, so reduces anxieties. The first section of your LCG comes into your mind. So you have to reduce his anxiety. Make sure the partner is there. Ask her to change the positions and make sure she is well hydrated. Okay. So that is why the contraction will come into some. So despite of this more contraction, then you have to, if there is a changes in the fetal heart rate, then you have to reduce the contraction, not do the ARM. If it is only 2 contractions, 6 centimeters, if the progress is poor, then I will do an ARM, not for the baby's sake. Okay.
Yes,
That's a
ma'am.
more one learning in this. Do never ever do ARM when the baby, especially in distress. Okay, so now it's to the Ferina. Ferina, this is a case for you. Just read the
Yes,
case
ma'am.
and let read the CTG.
Okay, so this case is primary GDM on meal plan, 38 weeks and spontaneous labor. So head 1/5 palpable and cervix is well effaced, 7 centimeter dilated, membrane absent. ARM was done 4 hours ago and clear liquor, vertex at -1 station, and she had there's no caput or no molding. So in this case, we can see. The contraction is 4 contraction per 10 minutes, and there is the baseline 4 contraction is there, and baseline heart rate is 120 beats per minute, and there is acceleration you can see over here in the beginning. There is two acceleration, and there are variable deceleration, but it is also short and it's recovering quickly. So we can continue the CTG and we can monitor the patient further in this case.
Okay,
As
so you
she's
see Dr. C. Bravado. If you
the
put a
risk
Dr. C.
factor she's
Bravado, where
having
it
is
is comes?
GDM.
Huh?
Risk factor she has is GDM. Other than that, the CTG seems to be fine, so we can watch for. We can continue
She has
monitoring.
an antenatal risk factors of GDM and intrapartum risk factors of membrane absence.
Membrane absent is.
So that also you have to take care. So that's a new risk factors which is developing. How many hours mention? It is 4 hours.
4 hours, yes.
Okay, that you have to mention. There are 2 risk factors. And C is contraction is fine. There is adequate rest period in between contractions.
Between the contraction.
Also fine. And baseline heart rate, you will be reading in between 2
2
decelerations.
deceleration. Yes.
Okay. Okay. And a baseline, wherever you read the baseline, that is the same place we will be reading a
Variability also.
variability. That is also normal. And what happened here? Is it an acceleration? I said acceleration has to come from the baseline up and go settle in the baseline. So is it settling in the baseline?
No, ma'am.
Okay, then
Yeah,
there is no acceleration. It's an active baby. That's a different thing. But there is no accelerations. This is not, it is just an active baby is coming and settling in upper baseline, but it is not coming down. Okay.
Yeah. Okay, ma'am.
Fine. So it is not coming down. It's a part of hyper variability. So here, even this is not an acceleration. Okay, it's a small up and coming down. So, and these are all the things is like a
baby's movement.
baby's movements. We really don't know whether it's accelerations. As per the definition, it has to go up from the baseline and coming to the baseline. 15 beats. Then only you can call it as an acceleration. Okay, fine.
Okay.
And are you worried about the decelerations?
Ma'am, it is picking up again, so it is very short only. Again,
so why you have to reason out why you want to be worried about? Why are you telling this is a variable decelerations?
It is not along with the contraction, ma'am. It is.
Okay. It's not with a contraction. It may contract. It comes. What is the definition of variable decelerations? Okay. So it's a variable in length. Okay. Variable in form. And it may come along with the contractions. It may not come along with the contractions. It may be repetitive. That means every contraction it may come. It may not repetitive. And it is a very short or it will be very broad. Okay. Whenever you have a there will be a shouldering. See here, there is a high up and then a period of increased heartbeat followed by decelerations. That is called compensatory mechanisms. Baby have one vein, 2 arteries. Okay. So when the compression happens, there will be a tachycardia because of the high pressure tachycardia, and then deceleration starts. Okay, so that is why the shouldering. If the shouldering is there, the baby's compensatory mechanism is fine, and also it is a very fleeting decelerations, quickly deceleration. So it doesn't have any problems, and without concerning features. So yeah. So but initially there is no deceleration, but towards the end it started having more decelerations. But every other contractions it having a deceleration. Correct?
Yes, ma'am.
Okay, so it is almost like a non-repetitive decelerations. These are the things, there is no deceleration, only.
Deceleration.
Okay, so whenever you see a deceleration, you have to time the decelerations, but type the deceleration, time the decelerations, and variability in any concerning features, repetitive or not, and one more things, whether it is coming to the baseline or not.
Baseline or not.
Okay, so the baby staying there in the baseline should be more than the deceleration timing. So what is the duration of decelerations? How will you calculate the duration of each decelerations? Each decelerations. What is the duration of acceleration? What is the duration of deceleration? Okay, so starts and coming up. So this is the durations, total durations. Okay, so 1 centimeter or 1 minute. Okay, so the duration is 60 seconds here. The duration here is very short. This is 1 full centimeters, but here it's almost 30 seconds. Here it's going up and coming down. So what is the duration? It's almost 45 seconds here. Okay, so that is like this is the durations. Coming up and staying back to the baseline is duration. So the duration of deceleration is 1 minute here, and baseline is more than 1 minute.
More than 1 minute.
Okay, so if it is like that, then that's a normal mechanisms baby is going through it. So that is fine. So now finally giving me the impressions, what is it?
It's a normal.
It's coming into the white.
White. Yes,
Okay, so white. So why it is white? Because it is a variable decelerations.
But there is
Contractions
no
is fine, baseline heart rate is fine, variability is fine, and you have a deceleration of variable deceleration with no concerning features.
Yes, ma'am.
Correct. So it's almost ARM done. ARM for 4 hours for 1 centimeters. So what will you do now?
We have to continue monitoring the patient.
Okay.
And give hydration. We have to hydration we have to monitor, and then left lateral position.
Okay.
And if there is any changes in the CTG further, like any increase in the deceleration, then we have to monitor.
Generally reassess after 1 hour or reassess after 30 minutes?
After 1 hour.
Okay. So will you do accelerations because it's membrane rupture for 4 hours?
Sorry,
We have
ma'am.
not done, it's a spontaneous labors. We have not given any oxytocin or anything. Will you do acceleration now?
No, ma'am, because contraction is good, so we can.
Very good. You have adequate contractions. She is anyway progressing very good contractions. So we have minimum 3 contractions in 10 minutes. That's fine. Less than 5 contractions, that is 4 contractions. So she is having 3 to 4 contractions in 10 minutes. So she is getting, with this, she has to progress. So as you say, we will be giving a tender loving partner, and then make sure all this LCG fit on to the category. You assess the CTG after. Will you continue the CTG?
Yes, ma'am. We can continue the CTG.
You won't discontinue the CTG, right?
No, ma'am.
Why you would like to continue the CTG?
Because there was variable deceleration, so we have to monitor further.
So if it is a
if it is
normal
prolonging,
CTG, will you discontinue?
no, ma'am, and because she's in the no, I won't be discontinuing it, ma'am. I'll be continuing to monitor only.
Why?
Because she's already she's having 7 centimeters. She's dilated, and
yeah. So this lady, even if it is a 4 to 5 centimeters, she is in active labors, coming into the high risk category of GDM. And then intrapartum, another high risk category was come, like membrane rupture.
Membrane rupture.
So there are two high risk categories. So she falls into the continuous CTG monitoring category. So you will do continuous monitoring, but you will reassess after 1 hour. Okay. So you won't be
Yes, ma'am.
bothered about this variable deceleration with no concerning features. How many hours it goes, you won't be bothered about, right?
Yes, ma'am.
With concerning features comes only if it comes into the amber color.
Number
Okay, done. So you'll reassess her
in
after
1
4
hour.
hours or 2 hours. Pelvic examination.
Pelvic examination after 4 hours, ma'am.
Okay. Reassess the CTG after 1 hour.
Yes, ma'am.
Okay, continue the CTG. CTG is after 1 hour, you'll do it. Okay. But the CTG will be continuous monitoring. So this is how your variable, whatever the the picture I have highlighted here. So whenever you see the deceleration time in relation to the contraction, whether it is early, variable or late, and duration of each decelerations and rate of return to the baseline, whether it is repetitive and concerning features. Concerning features is broad, W shape, bifid shape, presence or absence of shouldering, and variability within the deceleration, whether it is coming to the baseline or not. Then these are the amber. White is like variable deceleration with no concerning features, repetitive. So these are all in the NICE guidelines. You go and read. Okay. Now move on to Elakia. Elakia.
Yes, ma'am. Yes, ma'am. So it's a G2, A1, 38 weeks, left for spontaneous labor. There are no risk factors. Abdomen examination showed 3/5 palpable and vaginal examination 4 centimeter dilated, well effaced, bag of membranes and vertex at -2 station. And the CTG was for the last 1 hour was as follows. So first, there are no risk factors.
1 second,
According
Ilakya. 1 second. So this is a CTG 4 centimeter, 38 weeks spontaneous labors, BOM plus vertex -2. So this lady comes under the category of continuous CTG without seeing the CTGs. Whether you will do a continuous monitoring in labor, she is in active labor, correct? You will put
Yes,
a
ma'am.
partogram and everything. So will you do
Yes,
a
ma'am.
continuous monitoring here or will you do intermittent monitoring?
Intermittent monitoring,
Why?
ma'am. Ma'am, she has no risk factors. She's in spontaneous labor. There is no, we have not augmented the labor with any oxytocin.
Okay.
And the bag of membranes are still intact. So I
Okay.
would say intermittent monitoring, ma'am.
Intermittent monitoring, how will you do each trace? How many minutes you will do one trace?
For before and after a contraction, ma'am.
Okay, that is intermittent monitoring. So if at all, if you
Yes,
do a
ma'am.
CTG, will you do admission CTG for her or not?
Yes, ma'am, we will do an admission CTG because then only we will know what the baseline is.
Okay, so this is a CTG now. Now read the CTG.
So again, no risk factors, ma'am. And then the baseline would be about 140, looks like 140 to 150 is the baseline. And the variability is
So
again
when you
10
start
to
the CTG, how to read the contract? You have to
the
start nasal.
contractions.
Always remember the mnemonic. Remember the nice chart. Recheck with
Yes,
the
ma'am.
chart and put it in the Dr. C Bravodo. Then only it is easy for you, even for your juniors or next duty person to look into the facts correctly. Okay.
Yes, ma'am. So contractions, about 4 contractions for 10 minutes, lasting about 40 seconds each, 30 to 40 seconds approximately. And the
Okay.
base,
So here the contraction duration, how will you calculate it?
ma'am, again the same, the box, ma'am, with the box I calculated.
Okay. Okay. Sorry. So box calculator. So is
Yes, ma'am.
this a contraction or a duration or this is a duration?
No, ma'am. The peak, I would say the peak, ma'am.
Always the duration
Yeah.
is this time. Time is like here
Okay.
only, no. Time is in x-axis. So do not forget.
Okay.
Time is in
Okay.
x-axis. So the duration
Okay.
will be this one. Some of the contractions is like 15 seconds. Some of the contraction 30 seconds. This is almost like 60 seconds.
Okay.
Okay. So the peak is an intensity.
Okay, yes, ma'am.
Okay. Okay. So peak is an intensity. Sorry. Okay. So peak is an intensity.
Yes, ma'am. Yes, ma'am.
Okay. So this is 4 contractions. So when you
Yes,
said 30 seconds, that's why I so it's varying varying duration of contraction, each contractions. So that is why when I say rest periods between 2 contractions, there is at least 2 big squares we need. At least
Yes.
1-2 minutes we needed for the baby to recover. Okay, so contraction is over. Now coming to the baseline heart rate.
Baseline heart rate is about 140 beats per minute, ma'am.
Okay, 140, 140. Where do you read the baseline? So this is almost like more of baseline. So
Where there is no
almost
accelerations or
135.
descents.
I agree. It's almost 135. Mm.
Yes, ma'am. And the variability is about 10 to 15 beats, ma'am. Again, I will
How
see
come it
where
is
there is no
10 to beat 15 beats? So this is almost like a one big square. Okay. So here
yes,
each
ma'am.
small square is 5 beats. So I
Yes,
can
ma'am.
see only the 5 beats here. Y-axis is the beats. Okay.
Yes, ma'am, but it's going from like 130 to 140, ma'am.
120, 125, 130, 135. Sorry, 120, 130, 140. So 135 is the midline. 135 is the thing. So it is going around 135, right?
Okay, ma'am.
So it is only 5 beats. So
Okay.
exactly here it's 130, 140, but it is not moving up. So if you take 1 full minutes box, this is 1 full minutes box. So it's almost like it's
5
like 5
beats.
beats. Maybe you can say if you keen on to computerized CTG, if you put it, you can say it is 7 beats may come. It's not more than that. Anyway, okay. Variability
Yes,
is
ma'am.
5 beats.
Variability is also fine. And regarding the D cells, ma'am,
Mm.
it's early D cells, ma'am. It's coming along with the contraction.
Mm.
So it's early D cells. And there are no other concerning features as such.
Okay. See, if you say this sorry, I'm interrupting again. If this area, if you say the variability is almost like 5 to more than 5 beats, okay. But when you see this, whenever you see the baseline, wherever you see the baseline only, you will be seeing the this one. So here, if you say it is like a pencil-like things, almost like a less than 5 beats only. Okay. So
Okay,
if
ma'am.
you fully see, this is a little bit of reduced variability. Okay, so almost 1 hour. This said variable early decelerations. So there is a say in when you define the early deceleration, when the definition is such, whenever there is a contractions, there will be a uniform pattern of contraction. Uniform, it's a mirror image and it will recur, uniform it will come.
Yes.
Okay, but here it is one vacational fleeting contractions as deceleration has happened.
But it is again mirroring with the contraction, the two D cells here.
But according to the definition, it has to come uniform, pattern has to repeat.
Okay.
It
But the
is not
pattern isn't
repeated. You have good
repeating after this.
accelerations. Why it is not repeating? If it is a head compression, it has to persistently stay there as a head compression, right?
Yes, ma'am.
And only 4 centimeters. Will you suspect 4 centimeters the head compression happen?
No, ma'am. And
Okay.
3/5 palpable.
So why she has to have an early decelerations?
It's probably a variable D cell only, ma'am.
Some variable deceleration is there. Okay. And if it is a 140 beats per minute, if it is a 140 beats per minute, how many beats it's going up?
The onset to the nadir
15
is
beats.
less
Okay,
than 30
it is a little
seconds.
broad and it is
Yes, ma'am.
duration is also more. So it is really concerning, even if it is, why it is really concerning?
The pickup
It's only
is
one
a
concept.
little. The pickup is after the D cell, the pickup is a little late.
Pickup is little, but it is not recovering. It is not recurring in any of the thing. It is not repetitive. Variable with concerning features only we are worried.
Yes, ma'am.
So
But
how it difference from the previous one and this one? You had no risk factors, contractions are 3 contractions, 3 to 4, baseline rate is fine within normal range, and variability is 3, less than 5 is reduced, and no accelerations, and there is a deceleration is there. Okay,
it again comes under suspicious
why it is suspicious?
because there are two concerning features. That is, one is the variable D cells and late pickup, and then the variability is also less than 5.
So when there is a two problems, the variability here holds more important than the decelerations. When there is a variability is very less for a longer time, even a small deceleration and single decelerations has a value. So what do you, it comes under suspicious. So what do you do?
I would, after this, I would put her on continuous monitoring.
Okay, continuous monitoring. So you will be putting another 30
Yes.
minutes, it's going to be same.
I will put her on continuous monitoring and adapt the other measures as well.
What are the
Get her hydrated, left lateral position, and all of those. I will do the first steps for initially, and then if along with continuous monitoring, if it persists, then I will see if she's put on any other
Okay,
oxytocin or anything and stop
okay,
that. And
okay. So he's just 4 centimeters. Will she deliver? If the same condition persists, same findings.
same
So
findings after how many hours, ma'am?
another 30 minutes. Even CTG with less variability for 50 minutes is red color. It's I have
Yes, ma'am.
mentioned is a pathological. It's actually pathological. Should be a pathological. Okay.
Yes.
So here, even if it is a ARM done clear like her, if it is persist and she no way going to deliver. So this baby will have some amount of hypoxia is going on.
Because of the variability. Yes, ma'am. Then
Because of the variability, less variability. So either it is not a sleep pattern.
no.
Sleep pattern, why it is not a sleep pattern? Because the CTG for more than 1 hour, it's the same thing as that. I have given only 40 minutes stays. More than 1 hour, it is continues to be like that. Why it is not a sleep pattern? The deep
The
sleep,
sleep, it's for only for 30 minutes, ma'am.
only for 30 minutes. That's the reason. So either you continue, you do a resuscitative measures. If the baby's variability doesn't pick up, then probably you have to, if the findings are same, probably will be and delivering by other methods of as early as possible. Okay.
As early as
So
possible.
we'll move on to the next case. Dr. Shakti Jaypriya.
Yes, ma'am. Yes, ma'am. She's gravid to para 1 live one and the 38 weeks of gestation, spontaneous labor. She has no risk factors. On per abdominal examination, head is 1/5 palpable. The per vaginal examination, cervix is well effaced and 6 centimeter dilated, and the spontaneous rupture of membranes with clear like a draining PV with vertex at a -1 station. And assessing this CTG, definitive risk, there is no definitive risk, ma'am. Contractions for 10 minutes, there is 4 contraction, each lasting for more than 40 seconds, ma'am. It's not coming to baseline, and the intensity is 60. And then accelerations, the baseline heart rate is
120.
120, ma'am, 120 beats per minute.
Okay.
And then accelerations, there is 2 accelerations noted, ma'am. Decelerations,
Okay. Acceleration, this is going up and coming down to the baseline. Okay.
yes, ma'am.
The baseline, it is coming up, it's going. Okay. So acceleration is that.
As such, there is
What about the variability? Where do you read the variability?
In between accelerations.
Where you read the baseline only will be variability. So what are
Okay.
they? These are all the variability or accelerations.
This is not acceleration, ma'am. This is showing saltatory pattern like the hyper variability.
What is hyper variable? How many beats has to go? This is only almost like a 1 minute. Okay. How many
Yes,
beats
ma'am.
up and go? So one from 120 to 140. It's almost this. It falls in this square only. It is 20 beats only. More than
Okay,
20
ma'am.
beats is saltatory.
More
So it
than
is
25
variability.
bits is high,
It
hyper
is
variable.
it is a moderate variability. Okay, not
Yes, ma'am.
hyper
Okay.
saltatory pattern. Okay. Okay. There is no decelerations.
There is no decelerations, ma'am. And then
Tell me.
assessing its no other concerning factors.
Yeah. Okay. So I would say these two things maybe accelerations, but it could be so usually when the mother is like pushing, okay, when the mother is having a contractions, okay, the accelerations may not have happened. Babies won't move fast. So could be this can be acceleration. These two are accelerations compared to these two because it's correlate with the contractions. This is called mountain peak sign.
Okay, ma'am.
Okay. So it's a false alarming that it shows that it looks like an acceleration. Probably it may not be an acceleration, but it's a very good trace. Baseline is fine, moderate variability, and she is 6 centimeter dilatation, very good contraction, good progress. She is going to deliver. So this typically happen in the second trimester when she faster progress, that's fine. So when you see an acceleration, this is acceleration, nothing wrong in telling this as an acceleration. This as an accelerations, but do a logical things. The acceleration has to go from the baseline coming down to the baseline. So here the baseline, if you write, if you see it is 120, you have mentioned here, it is false around the baseline, but here and all, it is the baseline is going up little bit. Okay, from 120 to 130. So this is also 130. Okay, so if you say these two are accelerations, this is a false accelerations. These are all the false accelerations. It's because it's correlate with the contractions. So acceleration starts with baseline, come back to the baseline. If it not, it's not be an acceleration. In intrapartum, there is no acceleration presence or not. It doesn't matter. So don't worry about that. Fine. So it's a normal and she's going to deliver. Okay. So that's what, this is how you have to finish up. This is coming go up and continuous and coming down. So that is what accelerations. So the baseline, it has to touch properly. Even two accelerations, it cannot be considered as a two accelerations. Here it's okay accelerations. So it is going up and coming back and coming to the baseline here only. So that is what acceleration definitions, rate from the baseline and time of return to the FHR to the baseline. It should not stay back longer and accelerating like that. So now Asha, you was.
Yes, ma'am. She's a primary 40 weeker, induction of labor done with prostaglandin E2, and there is no as such any definitive risk. On abdominal examination, head is 3/5 palpable. Vaginal examination, cervix is well effaced, or 3 centimeter dilated with bag of membranes, vertex at -2 station, ma'am. In this patient, there is no definitive risk.
No
Contraction
definitive risk. What? Induction
for
of labor.
induction of labor.
Okay, so you had a definitive risk for the baby, risk for the mother, antenatal risk, fetal risk, as well as intrapartum risk. So you have to divide like that. So here, induction of labor with PGU to gel, she's coming into the category of high risk category. You need continuous monitoring. This was one
Okay.
CTG has been done after say, gel or pre-gel, whatever it is. Then that was not mentioned here. Okay, and whenever you see the CTG, it's a make sure it is adequate paper. Like it is almost 30 minutes CTGs, 30 minutes paper is enough to interpret. Okay, yeah. Now interpret.
Contractions as such, there is only one contraction, ma'am, which is for lasting for more than 45 to 60 seconds. And there are
What are they? What is this?
and these are also small contractions with less intensity, 40.
Okay, this is all called uterine irritability.
Irritability.
This is, if you check it, like you will be having irritable uterus kind of things if you palpate. So sometimes this is what contraction, there won't be any contraction, but it will be irritable uterus. Okay, so now coming to the baseline rate.
And the baseline is around 160 beats, ma'am.
Okay.
And there is a deceleration. First one and the second one, it is a very late deceleration, prolonged deceleration.
Okay. Define prolonged
Pickup
deceleration.
is late.
Define prolonged
And
deceleration.
it is alarming more than 2 to 3 minutes, probably.
So what do you do? So you forget about this trace, the left, right off. So you forget about this trace. Do not look into the trace. So you are being called to the labor room to see this trace. So what do you do? How will you interpret? Finally,
prolonged deceleration.
Prolonged deceleration. So what category it comes under prolonged decelerations?
Red.
Red. Okay. So red. So it is pathologicals. So what do you do? Okay. See, you saw that when this is an urgent things. Don't even know that recovery is there. Before recovery, you have been called. Okay. So what do? It is you define it's more than 2 minutes, 3 minutes, it's a prolonged deceleration. So once it cross the 2 minutes, it's a call for grab. It alert the bell. Okay. So you go there. So you enter there. So he alerted. What instruction you will do?
I will ask them to prepare herself.
Okay, you prepare herself. First of all, what you go and assess, I need to identify the cause. And then what you have to reason out what is the reason, what is the diagnosis. You have to make up a diagnosis.
Yes.
Okay, then all and one term. Then you have to treat her. The step-by-step approach. You need to know whether it is reversible or irreversible, basically. What is the cause? Whenever you have a 2 minutes or 3 minutes of decelerations, most important things it has to strike is whether it could be
Heart prolapse.
heart prolapse,
Abruption.
Uterine hyperstimulation could be a cause, but here it's not that.
reversible. Okay, reversible. Reversible uterine hyperstimulation. So irreversible, you have to rule out. Irreversible, whatever Asha said, that has to be taken on to the theater. So we cannot apply the rule of 3. So what do you do, Asha? So there is no abruption. You did a perivaginal examinations. There is no bleeding. Uterus is not much contracted, but it is irritable. It is not hypertonus. Okay, you ruled out abruption. You ruled out.
I put a speculum and I'll look for the color of the light.
Why you do a PV itself? Okay, why you want to rupture? When the baby is abnormal, do not rupture.
No, ma'am, I'm not rupturing it. Maybe by per speculum only I can look for
Vaginal examination, abdominal examination. See the tone. See here, only thing you have to rule out 3 things. One, the card prolapse. Maybe you have to see the color of the more than color of the lichen. You can do a speculum, see the card prolapse, or you can even do a PV, feel the card. Okay, so that's why the 3 things you have ruled out. Then now what do you do? So when do you call for help? As soon as you see the 2 minutes for exceeding the things, you will be called for help. So that's the first step. Then you have to find out the diagnosis. What is the cause? The 3 causes you have to rule out. One is abruption, cord prolapse, and loss of baby things like ruptured uterus. Okay. And then you hyperstimulation, hypotension. Is there any epidural, any sudden change in the maternal positions? All those things. So that is for look for causes. Second, look for causes. The third thing is fetal reserve. Second thing is fetal reserve. So whether the fetal is irreversible means whether the baby is having good reserve or not. Good reserve, you have to see the previous heartbeat, previous 3 minutes and first 3 minutes of decelerations. Previous 3 minutes, see the baseline heart rate. But what it is, 160. Is it pathological? It's on the highest side, tachycardia. For a 40 weekers, you're not expecting 160 beats per minute. You will be expecting for the term 40 weekers, 120 to 130, not more than that. Okay. So 160 is the tachycardia here. And there is a less variability and there is also a deceleration. So first 3 minutes, there is lots of baby's reserve is poor when it started deceleration. And during the first 3 minutes of deceleration, look for the variability. Is there any variability? Almost less variability. Less variability. Okay. Then see the depth, how many beats it's coming down. Any deceleration comes to 80 beats. That's not a good. And lasting from 80 beats, lasting for a longer time, more than 3 minutes. More than 10 minutes, it's a pre-terminals. More than 30 minutes, more than 3 minutes, it's a poor sign. The baby is not coming back to normal. So when you go into the labor room, when you see the cause, do the PV, rule out irreversible cause, then you have to see baby's reserve is good or not. Here the baby's reserve is poor. Okay. So baby's reserve poor achna nama vande we won't be giving her you will be doing all the sorts of left lateral positions, IV fluid. You will treat side by side, but you won't wait. You will do the PV. If she's not going to deliver, then we will be taking her to the theater. Anyway, if she recovers also, it may again have a deceleration in some part of time because uteroplacental deficiency is there. That's why baby is having tachycardia, some deceleration, less variability. Okay. So then when it is recovering, see the variability, signs of recovery, how the baby is, how the current status when you enter into the labor room. So this is how you will be making the signs, making the diagnosis, step 2. Step 3 is you will be treated or making a decision to go to the theater or treat it. So if it is a reverse, our baby comes under the category reversible, but still a poor fetal reserve. So we need to deliver as soon as possible. We cannot treat it. So if it is a reversible, if it is not a previous 3 minutes and during the first 3 minutes of CTG is normal, then we can wait. Okay. So you apply for a 3 minutes rules. Okay. Do a resuscitations. If 6 minutes, no recovery, shift to the theater. If 9 minutes, no recovery, then the 95% of the babies will recover in 9 minutes. If no recovery, then we have to deliver her. Fine. Commence emergency deliveries by 15th minute if there is no recovery.
Yes.
Okay, we'll move on to next CTG for Fariha. Fariha?
Yeah, ma'am. This is a primary 38 weeks of gestation, spontaneous labor, and no risk factors. On per-abdomen examination, head is 1/5 palpable. On per-vaginal examination, cervix is well effaced, 8 centimeter dilated, membranes are absent, vertex at -1 station, clear like a draining, and CTG for the last 50 minutes. So by Dr. Bravado classification, first she belongs to low risk category, and contraction it is about 3 to 4 contractions, ma'am. The last schedule, it is about 3 to 4 contractions of moderate intensity lasting for about 45 seconds, 40 to 45 seconds. And the baseline rate is 150 beats per minute, ma'am. In between the contract, it's 150 beats per minute. And the variability is almost, it is less than 5 beats per minute, ma'am. And there is no acceleration in the CTG. And deceleration, moreover, it comes as variable deceleration, ma'am. With concerning characteristics is also there, I guess, because there's loss of shoulder. I couldn't say any shouldering and all, and there is slow return to baseline of the variable decel is there, ma'am.
See, if you cut down all the thing, it is somewhat like coming to the baseline, right, ma'am?
Yes, ma'am.
Though it is not staying baseline for a longer time, but at least it is coming to the baseline. So this rounds is almost like a baseline. You said 150, it's almost staying in 150. It's
Yeah.
not decelerating for longer time. Of course, there is a decelerations. Okay, so 8 centimeter dilated, membrane absence, clear like a draining, 50 minutes. So final thing, what do you say? It's a concerning features.
Yeah, ma'am. Variable deceleration with concerning characters is also there, ma'am. As the duration
It's a
lasts for
pathological
15 minutes,
CTG.
I just say it's a pathological CTG, ma'am.
Okay, so what do you do?
Expedite delivery, ma'am. Contractions, ma'am.
Okay.
Let's look for other causes of variable deceleration, ma'am. Because when she's 8 centimeter dilated and head compression is almost common in all cases, ma'am. I mean, cord compression is almost common, ma'am. Then
Okay.
maybe I'll just look whether oxytocin is going on, ma'am.
Okay, fine.
The oxytocin is there, maybe I'll just stop it and I'll try some research measures to like put the patient in left lateral position, put IV fluid, and to see whether the variable deceleration and all is picking up, ma'am.
Okay. So when do you want to reassess? So you want to resuscitate the baby and you
Yes,
want to
ma'am.
expedite the delivery. Say this is almost like 50 minutes now. So when do you want to reassess the lady?
But I'll just put now I'll just put her in continuous CTG monitoring only, ma'am.
Okay.
Yes, ma'am.
Then what do you? So how long you want to wait? How long you are happy waiting? So whenever you have a pathological CTGs, it's not like that. You mentioned that is a pathological. Each baby will be having a different reserve. Okay. So some babies will tolerate, some babies may not tolerate. So you will be, that is the reason you will resuscitating and continuing the CTGs. You are not immediately taking up the cesarean section. Out of all these things, your main point is the baby is coming into the baseline.
Baseline heart rate.
Okay. Though baseline heart rate is on the higher side. Why I am telling this is a higher side for this? There is one condition in the sticker I have given, whether the CTG baseline is appropriate for gestational age. So this 150 beats per minute, if you are seeing for the first time, this is may not be an appropriate for this 40 weeker. She's 40 weeker, right?
Yeah, ma'am.
Okay. 38 weeker. So term, anything its terms is like 140 is anything for the term is so it is not appropriate. So you have to see the previous CTGs, what CTGs already the baby is going for any compensated tachycardia. So probably the previous CTG, if you have it, probably it will be 140 beats per minute. Then already 20 beats, it's higher.
Yes, ma'am.
Okay.
Look for the
20
rebound
beats.
tachycardia comparing to the
So
previous.
that one problem is there. And there is having babies coming to the baseline. All babies having a variable deceleration, as you correctly pointed out. Deceleration is one way baby is coping up mechanisms in labor. So that's fine. So with this TAC 150 and this coming to the baselines, you will do a resuscitating measures, not immediately taking up for the cesarean sections, because compensatory tachycardia is still not worse. It's not gone into the decompensatory phase. So always remember this mnemonic called mother. So whenever you have any pathological or suspicious CTGs, see whether there is an excessive uterine compression, see whether it's an iotocaval compression, is there any maternal hypotension or additional effect of any maternal pushing. So M is for meconium, look for oxytocin, look for temperature, especially for the high tachycardia. Is there any hyperstimulation? Is he on epidural? How is the rate of progress? Any scar? So this is the mnemonics you will be doing it, looking for the cause. Then you have to cut down all this thing, treat the temperature, cut down oxytocin. If it is a meconium, either it is a significant or non-significant. If it is non-significant, thinner meconiums are more liker, then you won't be worried about that meconium. That is the reason ARM is not going to give us any benefit. Okay. And resuscitative measures, you remember this spoiled mnemonic. What is spoiled mnemonic? Spoiled is to stop your oxytocin if it is there. So in these conditions, even if she is on oxytocin, the first priority, though for me, the tachycardia has to come down and the variable deceleration, I'm not worried about it. The baseline baby has to stay longer. So I don't want the contraction to come. So even if she is on oxytocin, even if she is progressing, I will be stopping the oxytocin. I want the baby to be all right. Okay. And change the position. And oxygen, will you give oxygen or not?
Yes, ma'am.
No. Okay. Oxygen, by giving maternal oxygen, it not improve the baby. Only when the acute bradycardia, because of eclampsia, because of fits, because of maternal causes, maternal collapse, maternal cardiac, the oxygen will help the baby, not for other ways. Then IV fluid bolus, you can, if the baby is, my mother is totally dehydrated, not taken any fluid, give her IV fluid bolus. And probably if she is really hypotensive, give her some ephedrine and tocolysis. Do not forget tocolysis, not only for acute bradycardia, for this also. Okay.
Yes, ma'am.
Okay, so this is all. So I will reassess. Same thing if in persons, I will reassess, do the PV at 1 hour or half an hour, 30 minutes. When it comes to the pathological, 30 minutes. Only acute hypoxia, the rule of 3 immediately.
Okay.
So if she is in after 30 minutes, if she is in the same thing or if she is progressing or the condition improving, we will wait further. Okay, but if she is not progressing, if she is same thing or if the condition worsening, same PV finding, if she is not able to deliver, we have to deliver her by a cesarean. If she is full dilatations, probably the head has been descended, we will be delivering. So 30 minutes is in pathological CTG's reassessment.
Yes, ma'am.
Okay. But you have to do all these things, make the condition reversible.
Yes,
Fine.
ma'am.
Since I'm not going to the further cases because already it's around 7 o'clock. Okay, we'll stop with that. Rest of the 5 cases we'll discuss in some other time. Okay. And any other doubts, any other students, any chat questions in the chat box, we'll answer. Any questions? So panelists, do you have any doubts, any questions?
No questions, ma'am. Thank you, ma'am.
Who is Sukrit? I'm not asking Sukrit.
No, ma'am, no questions.
No questions.
No
Any doubt?
questions, ma'am.
Are you now confident? Always remember the mnemonics.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay. So start seeing the CTG, start practicing. We'll see you for the next month sessions. Okay.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Excellent discussions. Join late. Can we get the recording? Yes, the recording will be there in the Oxy website or YouTube. Okay, we'll share it in the students group. Okay, and I have to congratulate all 5 panelists. Excellent reading the CTGs. You have almost like the Dr. C. Don't forget Dr. C. Bravado, but your knowledge is excellent. All 5, you are excellent.
Thank you, ma'am.
Okay, good. Okay, continue see the CTG. Even if I see the CTGs, next time I will interpret differently. So do not worry about that, but follow the rules. Okay, and see the baby as a whole. Okay, CTG alone is not a standalone test. Okay, bye-bye for now. And I thank Sambat Madam, Dr. Meena, and my co-convener, moderator, Dr. Jayashree Gajaraj, and all other delegates staying there for a longer time. Thank you so much. We'll see you next sessions. And if you are able to wait, next session is 7:30. We'll be starting our CTG CRC clinical research webinars. So we'll be discussing a thesis discussions. So you have any doubts, we have a 3 experts for the next webinar. Any doubts on the thesis? So it is like already have done your thesis. What are the questions you will expect in your thesis? You can discuss with the experts. Okay. Yeah. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank
Thank
you,
you,
Chitrakala.
ma'am.
Thank you, Chitrakala and Shri. Priya. Bye.
Thank you, ma'am. Thank you, ma'am.